Thank you for the opportunity to present our work. We have no relevant financial disclosures. Abdominal aortic aneurysm, or AAA, is often asymptomatic, but it can be a life-threatening problem. This is the 15th cause of mortality in the United States and the 10th cause of mortality in men at the age of over 55 years old. 4 to 5% of sudden death actually happen by a ruptured AAA. Most AAAs are first identified incidentally on imaging, yet up to 35% of them can be missed or never reported. The decision to treat relies on the symptoms, but more predominantly on the size of the AAA. The inner observer variability in measurement can be up to 0.5 centimeter, and this can greatly impact whether we treat the aneurysm or not. Deep and machine learning have been widely used in imaging diagnosis. There is a large body of literature on deep learning in medical image analysis, heart sound classification, lower extremity Doppler sounds and carotid duplex studies, and even qualification and quantification of breath sounds in COVID patients. We think with the use of artificial intelligence, we can improve the quality of AAA care. This would allow for opportunistic screening so that we would never miss a AAA, streamline the workflow of AAA identification and reporting, and standardize the measurements for objective surveillance. And lastly, provide a tool for AAA registry development. So we set out to use deep learning-based approach to develop and evaluate an open source system for automated standardized maximum diameter of abdominal aorta from CT scans. We named this the A4 pipeline. For training, we used 35 CT scans from the STAR registry. These included studies with and without contrast, as well as those that were obtained before or after AAA intervention. The A4 pipeline was developed to segment the abdominal aorta from the L1 to L5 vertebral body across this 3D volume by training an NN unit on the total segmenter data set, along with manually annotated CTs of the large AAAs. We leveraged the pre-existing platform developed by the AMI group, or the Artificial Intelligence in Medicine and Imaging Center at Stanford. They have the COM2COM model, which allows for automated multi-tissue abdominal CT-based body composition analysis. As you can see, as in some of the graphs on the right side, there is the mineral density quantification of vertebral bodies. We have marking of the adipose as well as muscle tissue and its volume quantification in the middle. And on the left, we have organ identification in this picture, namely the liver, spleen, and pancreas. Of note, the code for the A4 pipeline is accessible to researchers through GitHub. So we use the 35 STAR CT scans and implement a spinal segmentation model of COM2COM to perform L1 to L5 cropping, and then trained custom algorithm on this data set to perform AAA segmentation. The algorithm then measures the segmented data from axial images to determine the axial slice that has the largest diameter. This also measures the minor axis axial diameter, which is closest to orthogonal. We then validated this algorithm on 242 scans and performed comparison of automated measurements against manual measurements, or our gold standard being board-certified vascular surgeon measurements. So the A4 pipeline can be run on large patient data sets for research studies, and the data we can gather from this include the maximal diameter, the slice number of the largest AAA diameter, and video of segmentation, as well as a graph of diameter progression. Let's look at example together. The image is being uploaded here. The DICOM is already in the system. It takes a few seconds for it to be analyzed. It gives you the largest slice. It gives you a video of the aortic segmentation and the diameter at each axial plane. And lastly, the diameter progression across the axial slices. This is a measurement web app that is open to everyone. You can use a QR code and test it out at home. Lastly, we set out to look at the agreement between the deep learning system and the clinician measurements. And we found, as you can see on this bland Altman plot, that there was great agreement between the AAA measurement by the system as well as those done by the vascular surgeons. The mean bias was approximately about 2 millimeter. And on the scatter plot, you can see the AI predicted diameter and the maximum AAA measurement correlated in majority of the cases. Specifically, the Pearson correlation coefficient was about 91%. The mean absolute error was about 0.5 centimeter, and the 3 centimeter binary accuracy was about 85%, and the 5 centimeter binary accuracy of 95%. Overall, the model tends to overestimate the smaller diameters and underestimate the larger ones. So in the future, we aim to refine this model further on outliers to improve our measurement prediction, namely on CT scans that have artifacts from embolic agents or fenestrated endografts. We hope to explore clinical integration of this model for real-time AAA measurement during CT scans. We hope to expand the application of this technology to other vascular anatomical measurements. And we're currently in the process of obtaining a 510(k) FDA approval using external data from the Bunker Health healthcare system for external validation. So to conclude, this deep learning tool shows high accuracy and reliability for measuring AAA diameters, closely aligning with clinicians' measurements. The model promotes a standardized, scalable approach for AAA measurement and reduces the risk for clinical errors. This open source nature allows for continuous improvements and adaptations by the greater global medical community. Thank you for your attention, and I'm happy to answer any questions.